Hello everyone, welcome to video series on renal function test. This is part 2 or second video in this video series of renal functions test. If you haven't watched part 1, please go and watch the first video, then come back to this video where I have explained the different classifications of renal function tests. Today in this video I am going to talk about urine analysis or examination of the urine. Under urine examination, so we need to study under 3 categories, that is physical examination or physical test, chemical examination and microscopic examinations. So we will study one by one. Under physical examination of the urine, first and foremost we need to examine the urine appearance and color. Normal urine color is amber color or pale yellow in color, and it should be clear and transparent. Suppose the collected urine is red in color, then your interpretation should be maybe patient might be having renal colic or stones which might have injured the urethra, or there may be injury introduced while doing catheterization, or injury might be due to the stones. And some malignancies or cancer patient, we might see red color urine because of bleeding. And certain types of porphyria also leads to red color urine. Suppose the color of the urine is brown in color, then it is due to hemoglobin and myoglobin, because hemoglobin it will be oxidized and degraded to acid hematine and it will be brown in color. So urine looks somewhat brown in color in case of hemoglobinuria or myoglobinuria. If urine appearance looks white and turbid, then you should suspect urinary tract infection due to pus cells. If the urine is dark yellow in color, then it might be due to jaundice. Specifically, it is obstructive jaundice. It could be due to intrahepatic obstruction or post-hepatic obstruction. Here only conjugated bilirubin will come to urine because it is water soluble, so we will see dark yellow urine. Sometimes patient might be consuming B complex in the form of tablet or syrup, then we will observe dark yellow color urine because water soluble vitamins, they are water soluble and excreted in the urine. This is about appearance and color under physical examinations. Again, if the urine is red, suppose it contains blood, then it could be a fresh blood. So then we have 3 inferences. Suppose blood is present while passing the urine at the beginning or start of micturition, then that blood might be due to urethral injury. The source of blood is from the urethra. If throughout passing urine there is blood, then that means the source of blood might be due to bladder and above. If blood is present at the end of the micturition or passing the urine, then it could be due to prostate or enlarged prostate and base of the bladder. Now we will see volume. So this volume, when we say volume, it is 24-hour urine output. Normal urine volume is about 800 to 2.5 liter per day. Suppose the urine output for 24 hours or within a day is more than 2.5 liter, then we call polyuria. So the conditions which we will observe polyuria are diabetes mellitus, where more than 5 to 6 liter of urine is excreted per day. In case of diabetes insipidus, the urine output is about 10 to 20 liters per day. In chronic kidney disease and later stage of chronic glomerular nephritis, the urine excretion is about 2 to 3 liter per day. So this is about polyuria. Suppose urine output less than 500 ml per day, more than 100 ml per day, then we can call it as oliguria. So this oliguria could be due to dehydration. Dehydration may be due to vomiting, diarrhea, or sometimes in case of burn, severe burn. Oliguria also seen in acute nephritis and acute renal failure. There is one more term called anuria. So literal meaning of anuria means there is no urine output at all, absolute nil output of the urine. This might be due to bilateral obstruction of the ureter due to stones, or sometimes acute tubular necrosis, and even in shock also there may not be urine output at all. But practically speaking, if urine output less than 100 ml per day, we can call it as anuria. Again, you need to remember the urine output or the total volume per day, it also depends upon the climate, temperature, and the person habit to drink water. Now we will see the smell of the urine. After collecting the urine, normal urine odor or smell is aromatic in nature. Suppose the collected urine, fresh urine is foul smelling, that suggestive of infection or urinary tract infection. pH. Generally, the pH of urine is acidic in nature. It's about 5.5 to 6.5. On an average, it is 6. We also see alkaline urine in some of the urinary tract infections. Last one is specific gravity. Specific gravity means concentrating ability of the urine. Suppose urine is highly concentrated, the solutes are more, so the specific gravity will be more. If urine is diluted, specific gravity will be less. The normal specific gravity is about 1.008 to 1.020. So these are all physical examination of the urine. So let's move on to chemical examination of the urine. First parameter we are going to observe is protein. If at all protein present in urine, we call it as proteinuria. Most of the time it is albumin, we can also call it as albuminuria. So normally there is small amount of proteins in the urine. It's about less than 150 milligram per day. Among these normal proteins, albumin, it's about less than 30 milligram per day. Normally we cannot detect with the routine test. In addition to albumin, we have globulins. It could be gamma globulins or other globulins or light chains of immunoglobulins. Then we have TAM horse Paul glycoprotein. These are normal proteins present in the urine which are secreted by the tubular cells. So albumin, globulins, TAM horse Paul glycoproteins together it constitute about less than 150 milligram per day, which we are not able to detect with the routine test. So we know now normal albumin in the urine per day is about 30 milligram or less than 30 milligram. Suppose the albumin levels in 24-hour urine is more than 30 milligram and up to 300 milligram, then we can call it as microalbuminuria. So more than 300 milligram we can call it as macroalbuminuria, or sometimes we can call proteinuria. So now what are the causes of proteinuria? And proteinuria could be divided into three categories: glomerular proteinuria, overflow proteinuria, and tubular proteinuria. So glomerular proteinuria might be due to nephrotic syndrome, where there is damage to the basement membrane, so usually proteins are leaked into the tubules of the nephron. Another causes for glomerular proteinuria is acute glomerular nephritis. Again there is leaky glomerulus, damage to the basement membrane. And diabetes mellitus. In diabetes mellitus, there is hyperglycemia, which increases vascular permeability. Overflow proteinuria. Here kidney might be normal, but there is increased circulating low molecular weight proteins. So these low molecular weight protein concentration is increased due to some other disease. So we will be seeing proteins in the urine. This is seen in multiple myeloma, and the proteins present in multiple myeloma is called benzoin proteins. We can observe these benzoin proteins in the urine in multiple myeloma. And hemoglobinuria, some of the hemolysis condition, there will be hemoglobin in the urine. Coming to tubular proteinuria, this is due to decreased tubular reabsorption of the filtered proteins, or maybe tubular damage. So here in this tubular proteinuria, there is decreased GFR, which we are going to study in the next video. And in tubular proteinuria, we could see retinol binding protein, alpha 1 microglobulin. These protein concentration are elevated in tubular proteinuria. So now we know what is proteinuria, what are the reasons for proteinuria. Now we will see what are the methods to estimate proteins in the urine. So there are three types of methods. One is qualitative test, semi-quantitative test, and quantitative test. So qualitative test is outdated now because more reliable, accurate quantitative tests are also there, and also semi-quantitative test is more popular. Under qualitative test, we have heat acetic acid test, which is just an academic interest. And also there is heat test for benzoin protein. If you heat to certain temperature, then there will be precipitation, and if you cool, the precipitation will disappear. Under semi-quantitative test, it is more routine, done in almost all laboratories. It is dipstick test. The principle used is dry chemistry. Dipstick test, I have mentioned here semi-quantitative test because based on the intensity of the color, so we will say approximate amount of protein present in the urine. It is not the exact concentration of protein present in the urine. Whereas quantitative test, it will measure accurate estimation of proteins present in the urine. So there are several tests like sulfosalicylic acid test, immunoassay, radioimmunoassay or ELISA, electrophoresis, high performance liquid chromatography or HPLC. In these quantitative tests, we can estimate exact amount of proteins present in the urine. So one more thing you need to remember, because most of the clinicians nowadays, they use what is known as protein to creatinine ratio. So they will measure total protein in the urine and total creatinine in the urine. So creatinine, it is derived from muscle, so its concentration will be constant. So the normal protein creatinine ratio must be less than 0.2 milligram per milligram. Suppose protein creatinine ratio is more than 3.5 milligram per milligram, then it is suggestive of nephrotic syndrome. Might be due to other disease, but in nephrotic syndrome we will see massive proteinuria. And in pregnancy, if the protein to creatinine ratio is more than 0.3 per milligram, then it is the risk for preeclampsia or hypertension during pregnancy. Clinicians also use albumin to creatinine ratio because proteins might be due to albumin and other proteins. So this is more accurate albumin creatinine ratio. It should be less than 30 milligram per gram of creatinine. Okay, milligram for albumin, gram for creatinine. Another parameter we can detect under chemical test of the urine is glucose. If glucose present in the urine, we can say glucosuria. Other than glucose, we can see fructose, galactose and pentose. Together, all these pentose, galactose, fructose and glucose, together we can say glycosuria. If glucose is present, we can say glucosuria. When there is glucosuria or glucose in the urine, we can suspect hyperglycemia. You must remember glucose start appearing in the urine when blood glucose level more than 180 mg per deciliter. This is what is known as renal threshold. That means whatever glucose filtered in the Bowman's capsule of the nephron, all the glucose reabsorbed back to the tubular vessels or capillaries. If our blood glucose level is less than 180 mg per deciliter. Suppose the blood glucose level is more than 180 mg per deciliter, so more and more glucose is filtered and it is exceeding the normal renal threshold, so we observe glucose in the urine and we can name it as glucosuria. It's seen in diabetes mellitus. Another reason for glucosuria is renal glucosuria. Here it might not be due to hyperglycemia but due to decreased renal threshold. So normal renal threshold is 180 mg per dl. Due to some reason there may be decreased renal threshold, then we can see glucose in the urine, or sometimes impaired tubular reabsorption. Example is Fanconi's syndrome. What are the methods to estimate glucosuria or glucose in the urine? So good old method is Benedict test, but nowadays more usage of urine dipstick methods. We can also detect blood in the urine by doing chemical test in the laboratory. So we already studied if blood present in the urine, that means we can call it as hematuria, or sometimes this blood may be hemoglobin, so we can call hemoglobinuria. We will observe blood in urine in ureteric stones or kidney stones, urinary tract infections, certain types of cancer or malignancies, enlarged prostate or benign hyperplasia of the prostate, glomerulonephritis. So all these conditions we can observe blood in the urine. So there is a test called benzidine test. By doing this test with the urine, we can detect blood in the urine, and also we can detect under microscopy, or sometimes if fresh blood is there, we can detect by naked eye. Also we can detect blood by doing dipstick method. Ketone bodies. There are 3 ketone bodies: acetone, acetoacetic acid, beta hydroxy butyrate. Among these, acetone is volatile, so it is expelled through the respiration, whereas acetoacetic acid and beta hydroxy butyric acid, we can see these ketone bodies in the urine. When these ketone bodies are present in the urine, we can call it as ketonuria. So example or clinical conditions where we observe ketone bodies in urine: diabetic ketoacidosis and prolonged starvation. In case of diabetes mellitus, even though there is hyperglycemia, glucose not able to enter inside the cell for the generation of ATP because of deficiency of insulin. So all the fats undergo lipolysis, undergo beta oxidation and produce ketone bodies. Under prolonged starvation, again every cells are lack of glucose for the ATP. In case of severe vomiting, prolonged vomiting, we can see ketonuria. Best example during pregnancy, those women they have hyperemesis gravidorum. Severe vomiting during the pregnancy, we can see ketonuria. Certain glycogen storage disorders like von Gig's disease, here also we can observe ketonuria. Test to detect ketonuria or ketone bodies in urine is called Rothera's test, sodium nitroprusside test, and even with the dipstick we can detect ketone bodies. Another parameter under chemical test, we can detect bile salts. Normally bile salts are not present in the urine. If bile salts are present, that means patient might be having obstructive jaundice. It could be intrahepatic obstruction or post-hepatic obstruction. The name of the test is Hayes test, or also known as Hayes sulfur powder test, where we need to collect the urine and sprinkle sulfur powder. If bile salts are present, this sulfur powder sinks to the bottom. And also we can detect bilirubin. Normally bilirubin is not present in the urine. In case of obstructive jaundice, again intrahepatic or posthepatic obstruction, we can see conjugated bilirubin in the urine. The name of the test which detect bilirubin in the urine is called Fauci's test. And also there is urine dipsticks available for bilirubin detection in the urine. So last category, so we finished physical examination of the urine, chemical examination of the urine. Last category of urine analysis is microscope. For the microscopic examination of the urine, we need to collect midstream urine sample, and it should be fresh urine sample. If you want to do the test after some time, we need to preserve this urine sample after centrifugation in the refrigerator. We need to do centrifugation after the collection of the sample. Then the bottom settled part or sediment from the centrifuged urine sample we need to examine under microscope. So if you observe the sediment under the microscope, we might see RBC. RBC I have already explained. It is hematuria, and the condition already we explained. WBC, if more than 10 WBCs per ml of the urine, it is suggestive of urinary tract infection. Pus cells, again suggestive of infection or UTI. Cast. What is cast? Casts are precipitated proteins. There are different types of like hyaline cast, granular cast, RBC cast and WBC cast. So all these different types of cast we can observe in acute tubular nephrosis, pyelonephritis, glomerulonephritis, chronic kidney failure, tubular disease, even in congestive heart failure and vigorous exercise. So these casts are nothing but precipitated proteins. We can see different types of cast in different conditions. Last thing we could observe under microscopy is crystals like calcium phosphate and calcium oxalate crystals in renal stones. Okay, these are parameters we could observe under urine analysis: physical test, chemical test and microscopic examination. So in the next video, that is part 3, we will discuss blood test to assess kidney function.